My name is Anne Grunseit. I'm an Associate Professor of Public Health at the University of Technology, Sydney, and an Adjunct Principal Research Fellow at the University of Sydney. Today I'm going to describe our study on community perceptions of government intervention for prevention. Although the majority of strategies designed to reduce risk for non-communicable disease have been implemented at the individual level, policy and environmental interventions have been shown to have greater impact at the population level, but we often find reluctance on the part of policymakers to intervene at these levels. The likelihood a policy or intervention will be implemented is the result of a range of intersecting contextual and structural factors which combine to form what has been termed a policy window. Being able to detect such windows is challenging, but a combination of strong relationships between policymakers and researchers and the availability of data on community support for intervention can assist in bringing about policy change. Hence, monitoring community perceptions is critical. However, few studies have examined change over time in opinion towards government intervention for the prevention of lifestyle-related disease. Those that have are mostly tobacco control surveys, which show support for a range of policies increasing over time. Other research on alcohol shows that levels of public support depend on the policy mechanism and which policies are already in place. Analysis of trends in support for government intervention in general, however, is lacking, which leads us to the current study. Our study draws on data collected in 2016 and 2018 for the National Australian Perceptions of Prevention Survey, or AusPops, to examine change in support for government intervention, as well as modifiers of change. There were three main sets of questions used in this analysis. The first asked about perceptions of the level of responsibility for health for a range of actors and organisations, including government and people themselves. The second set asked about support for specific interventions. These were a mix of strategies which were already in place, such as tobacco plain packaging, those that could be further strengthened, such as alcohol advertising restrictions, or have been proposed by public health advocates, but not yet implemented in Australia. Finally, we asked questions which were designed to tap into agreement with different conceptualisations of government intervention in general, covering framing such as paternalism, utilitarianism, and restriction of individual choice. The analysis compared outcomes for 2018 with those of 2016 and tested for differential change by demographic subgroup by including interaction terms. We also somewhat uniquely look for change in the variance of responses. That is, the first set of analyses looked for changes in means from 2016 to 2018, and the second looked at whether opinions became more homogenous or were more polarised over the 2 years. Now some selected results. First, responsibility for health. There was a significant increase from 2016 to 2018 in the size of the perceived role for government and food manufacturers in maintaining people's health. The most profound change was for government, where the unadjusted proportion of respondents indicating that they felt that government had a large or very large role in maintaining people's health increased from 46% to 60%. This contrasted with the lack of change for the role for people themselves. For some actors, there was change between 2016 and 2018, but it was modified by gender, age, or socio-economic status. For example, women increased their endorsement from 2016 to 2018 of a larger role for employers and schools relative to men. Secondly, for specific interventions, the proportion reporting that the government had not gone far enough increased between 14 and 23% in 2018 relative to 2016 for the specific interventions of bans on smoking in cars with children, lower speed limits in high pedestrian areas, and laws setting limits on working hours. the relative proportion wanting government action on setting salt limits of processed foods and compulsory immunisation at school entry, however, were lower in 2018 compared with 2016. Once again, significant interaction terms shows that there was change among some subpopulations but not others, specifically age and education subgroups for restrictions on advertising unhealthy foods to children and taxing soft drink. Interestingly, the differential effect of education for these two interventions shown here was opposite. The proportion of those with a university education, shown here in the green line, calling for government action increased relative to those with a high school education, the blue line, for advertising of unhealthy foods to children, but decreased for taxing soft drinks. Finally, for perceptions of government intervention in general, only agreement with the statement that government needs to make laws that keep people from harming themselves changed significantly between 2016 and 2018. But the effect was modified, so those aged over 55 increased agreement with this statement from 2016 to 2018 relative to those aged 18 to 35 years, and respondents with post-secondary education decreased their agreement compared with those with a high school education. The more interesting result with this set of questions was that all four statements demonstrated greater polarisation of opinion in 2018 compared with 2016. For example, these graphs clearly demonstrate similar overall proportions agreeing and disagreeing between the 2 years, but there is a shift to the stronger positions in 2018. So taking these findings together, what does this tell us? One of the strongest effects was the almost 14% absolute increase in the proportion of people saying that government has a large or very large role in maintaining people's health, and there was little evidence of community concerns of a nanny state. But there appears to be a gap between the role that the community perceives a government should be taking in prevention and the perception that that role is being carried out. Further, in contrast with contentions made by certain politicians, it appears that support for government to lead on prevention is compatible with strong but stable endorsement of personal responsibility for health. We saw growing support for greater action on 3 specific interventions between 2016 and 2018, as well as continuing strong support for greater restrictions on advertising unhealthy foods to children, perhaps signalling a policy window has opened for this particular piece of legislation. Although the majority still felt in 2018 that the government had not gone far enough in setting limits on salt in processed foods, there had been a significant drop from 2016 in support for action. Reformulation of the food supply is seen as a best buy for non-communicable disease prevention. The change in public support in our sample may signal a need for public health advocates to maintain the visibility of some issues that are yet to be effectively translated into policy. Our results showing differential change in perceptions across demographic subgroups points to where information and advocacy may need to be targeted at particular subpopulations to garner sufficient and uniform public support. The increasing polarisation of opinion may reflect more general trends beyond health. We speculated on whether this was because of the reinforcing nature of personalised news and information, especially through social media. But research for this mechanism for non-health social opinion has shown mixed results. Therefore, this might be an area to be explored in future, specifically in relation to the prevention of NCDs. In conclusion, there seems to be a call for leadership and upstream government intervention to support reducing risk for lifestyle-related chronic disease. The question is anyone listening? Thanks for your attention.